Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, a randomized phase 3 trial of maintenance bevacizumab with or without pemetrexed following first-line induction with bevacizumab, cisplatin, pemetrexed in advanced non-squamous non-small cell lung cancer, AVAPERL, MO22089, by Fabrice Barlese et al. My name is Howard Jack West, and I am Medical Director of the Thoracic Oncology Program at the Swedish Cancer Institute in Seattle, Washington, USA. My oncologic specialty is medical oncology. The AVAPERL study presumes the value of maintenance therapy after first-line treatment of advanced non-squamous non-small cell lung cancer and compares two continuation maintenance therapy strategies, with 373 eligible patients initiating first-line therapy with up to 4 cycles of cisplatin, pemetrexed, and bevacizumab at the lower dose of 7.5 milligrams per kilogram every 3 weeks that was studied in the European AVAIL trial. 253 patients, or 68%, had tolerated and not progressed on this treatment. These patients were then randomized to receive maintenance bevacizumab alone or in combination with ongoing pemetrexed until progression. The primary endpoint in this trial was progression-free survival, and it is notable and regrettable that it was not powered to assess differences in overall survival. Both arms demonstrated outcomes that were comparable to those seen in other trials of maintenance therapy, at least among the non-progressing patients who were randomized, as results by intent to treat in the broader enrolled population are not offered, limiting the ability to compare outcomes with these regimens to those in many other studies. But among those non-progressing patients randomized to a maintenance therapy strategy, the AVAPERL study revealed a striking and very statistically significant benefit in progression-free survival, doubling from 3.7 to 7.4 months from randomization, hazard ratio 0.48 and p-value less than 0.001, at a cost of greater adverse events, including cytopenias and asthenia, in the combination maintenance therapy arm, as you would expect. Overall survival results are immature but appear to favor the combined maintenance therapy arm. Notably, however, there was a striking difference in post-progression therapy administered, 57% in the bevacizumab maintenance arm versus only 39% in the pemetrexed bevacizumab combination arm. Looking at these results in the context of other maintenance therapy trials, whether switch or continuation maintenance, these studies are overall consistent with the outcomes from the ECOG 4599 trial by Sandler and colleagues of first-line carboplatin paclitaxel with or without bevacizumab, followed by maintenance bevacizumab alone after 6 cycles of the combination in the bevacizumab-containing arm. In that study, the median time to progression on the bevacizumab maintenance arm was only a few cycles after the completion of first-line therapy, leaving the open question of whether the maintenance therapy with continuation bevacizumab added any benefit independent of the combination with chemotherapy. Also instructive are the results from the Point Break trial, recently reported by Dr. Jyoti Patel, which directly compared the ECOG approach of carboplatin paclitaxel bevacizumab followed by bevacizumab maintenance to carboplatin pemetrexed bevacizumab followed by pemetrexed bevacizumab maintenance. This study revealed no significant differences in outcomes between the two arms as measured from the start of all first-line therapy, but it is important to note that if the results of that trial had been reported as an AVAPERL, focusing only on outcomes in the subset of non-progressing patients who proceeded on to maintenance therapy, those receiving the combination of pemetrexed bevacizumab experienced a markedly superior progression-free and overall survival compared to those receiving bevacizumab alone. Cross-study comparisons are always perilous, and especially so here, where the studies differ in which patients are included in the measures of outcomes, obviously demonstrating misleadingly superior results when there is a filtering in which those included are only the patients who proceeded through first-line therapy, tolerated it well, and responded or demonstrated at least stable disease. These are precisely the patients destined to do particularly well, regardless of the subsequent treatment administered. The AVAPERL trial reveals that pemetrexed added to bevacizumab provides a significant benefit, at least in the short term, when administered as a maintenance therapy. Importantly, the recently reported Paramount trial illustrated that continuation maintenance pemetrexed alone after first-line cisplatin pemetrexed, in the absence of bevacizumab in either arm, also demonstrated a highly significant improvement in progression-free and overall survival compared to placebo. Together, these results offer a consistent theme that the benefit of a well-tolerated non-platinum agent, specifically pemetrexed here, is not exhausted after 4 cycles of a first-line therapy, a conclusion also supported by the IFCT 0502 trial by Parole and colleagues that demonstrated a significant progression-free survival with continuation maintenance therapy with gemcitabine. What remains unknown is what benefit, if any, is conferred by the bevacizumab included in this combination, as well as whether the dose of 15 mg per kilogram as pursued in the US-led studies, or the 7.5 mg per kilogram dose generally favored in European trials, provides the most favorable risk-benefit and cost-benefit balance. The very important 3-armed ECOG 5508 trial is directly comparing maintenance bevacizumab at 15 mg per kilogram to pemetrexed alone or the combination of pemetrexed and bevacizumab, and should provide some insight here, at least in terms of the incremental benefit of bevacizumab at the higher dose. What we have not seen in AVAPERL is a significant difference in overall survival, a point that is worth remembering as we reflect on how little of an impact several other trials in advanced lung cancer have had in shaping our standards of care after demonstrating an improvement in progression-free survival, but not overall survival. Randomized trials of maintenance therapy have demonstrated that both switch maintenance therapy with docetaxel and continuation maintenance therapy with gemcitabine have produced significant improvements in progression-free survival that were only accompanied by compelling trends toward improved overall survival. Moreover, topotecan as a maintenance therapy strategy in small cell lung cancer has also demonstrated a significant improvement in progression-free survival. In none of these cases has this improved progression-free survival led to any meaningful consideration of docetaxel, gemcitabine, or topotecan as a clinically significant option in these settings. Having converged on the conclusion that overall survival is the definitive endpoint, the oncology community cannot lower its standards and be lulled into complacent focus on progression-free survival because a trial is architected to provide an answer to a question of secondary interest. If we have determined that overall survival should be the definitive endpoint for this clinical setting, whether a trial acknowledges this or not, it would be inappropriate and irresponsible for us to selectively apply different standards for one treatment over another when the most obvious distinction between them is not efficacy, but drug cost and marketing budget. In the face of such a convergence of evidence of efficacy differences favoring maintenance therapy, at least in terms of progression-free survival, it might be understandable for a clinical oncologist to be swept by this tide and misinterpret that these data represent a mandate for eligible patients to receive maintenance therapy in one form or another. In fact, all of the trials that have demonstrated a survival benefit have compared one group of treatment-responsive patients receiving more therapy to a group of treatment-responsive patients receiving less of that same therapy. In the JMEN and Saturn trials of maintenance pemetrexed or erlotinib respectively, compared with placebo, approximately 80% of the control arms of each study never received that agent with proven efficacy in chemotherapy pre-treated patients with advanced non-small cell lung cancer. And in the Paramount trial of cisplatin pemetrexed for 4 cycles followed by continuation maintenance pemetrexed or placebo, which demonstrated a survival benefit, we don't know whether these patients who received placebo would have received the survival benefit seen in the maintenance therapy arm had they resumed pemetrexed after a fixed treatment break or at the first evidence of progression. The Paramount trial wasn't designed to ask that question, but it is definitely relevant now that we have evidence that the benefit of pemetrexed is not exhausted after 4 cycles in non-progressing patients. The one consistent conclusion from the growing body of literature on maintenance therapy in advanced non-small cell lung cancer is that the subset of patients with a good performance status and not progressing on first-line therapy are the very patients who benefit most from further treatment with an active agent. An immediate transition after a fixed number of cycles of first-line treatment to maintenance guarantees that these patients receive the opportunity to benefit from more therapy. But the evidence supports the concept that patients who would benefit from a break from treatment due to cytopenias, cumulative fatigue, or simply a need for time away from the cancer clinic to feel well and be with family will do every bit as well if they are followed attentively and can initiate further therapy in a timely way after a fixed interval off of treatment or at the earliest evidence of progression. The trial of immediate switch maintenance docetaxel versus docetaxel administered at progression demonstrated the exact same overall survival in the 63% of patients who actually received docetaxel at progression as was seen in the immediate switch maintenance arm. And the EGFR mutation positive patients on the placebo arm of the Saturn trial of maintenance erlotinib enjoyed the same overall survival despite an overwhelming difference in progression-free survival favoring maintenance therapy. The equivalence of overall survival in these examples illustrates that treatment later is every bit as effective as treatment before, as long as patients have an adequate performance status and actually receive it. In this regard, it is important to note that, although results may be immature, fewer than 40% of the patients receiving maintenance pemetrexed and bevacizumab on the AVAPERL study received any further therapy post-progression, compared with nearly 60% in the bevacizumab arm. We have consistent evidence that responding patients are the ones most likely to benefit from subsequent therapy, so failure to shepherd patients safely to the threshold of additional treatment at progression represents a lost potential benefit. Our true goal should be to pace our treatments so that we can ensure that all of the patients most likely to benefit from multiple lines of therapy are able to reap the benefits of all effective therapies over the longitudinal course of their disease. Accordingly, when these treatments are available over time and the clinical question is the timing of therapy, the only meaningful endpoint of maintenance therapies should be overall survival. We cannot apply this standard selectively or lower our expectations simply because a trial is called a Phase 3 study on the basis of semantics, but is underpowered to provide insights about the truly relevant endpoint of overall survival. The evidence from maintenance therapy trials highlights that patients with responsive disease benefit from the opportunity for additional effective therapies, but we don't need to necessarily front-load our treatments if patients cannot sustain that pace. Advanced lung cancer may not yet be a marathon, but it is now much more of a distance race than it was in the past, and progression-free survival is only measuring performance in the first leg. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.